Hi everyone, this is the lecture on goniometry. It's the first subject that we're going to tackle in tests and measures. In the first lab we'll be talking about goniometry, how to assess joint range of motion for the upper extremity, lower extremity, and spine. Before we get to that lab, you all will have a project where you're investigating one particular motion and how to measure that with the goniometer. So hopefully you all have a good idea of how to start. I'm going to just talk a little bit about range of motion and goniometry, and then we will be ready to move into lab. So range of motion for joint. Of course, we abbreviate that ROM. We're going to talk about different types of range of motion, and you probably talked about a little bit this in kinesiology with Heather last quarter, but the first range of motion we're going to talk about is active range of motion, AROM. It's a movement of a body segment within the unrestricted or available range of motion that is produced by active contraction of the muscles crossing that joint, meaning the patient is moving the limb by his or herself, active contraction of the muscles crossing the joint. They're doing the movement, we're not. Active assisted range of motion, it's a type of active range of motion in which the therapist or another outside force provides assistance to the prime mover muscles to complete the motion. And we'll be talking more about this in 110 with Jamie. She'll talk about active assisted range of motion exercises, passive range of motion exercises. But the difference between active assisted and active range of motion is the person is not doing it entirely on themselves. There is either the therapist is helping or some other outside force is helping, like a set of pulleys or something like that. So there's some assistance in the movement. Passive range of motion, or PROM, is the movement of a segment within the unrestricted or available range of motion that is produced entirely by an external force. So that is little or no voluntary muscle contraction by the patient. So they are hopefully relaxing and we are moving their arm or leg. So passive means that we do it, the patient doesn't. Active means they do it, we don't. The end feel, which Heather talked a little bit about in kinesiology, it's the feel or sensation at the extreme end of passive range of motion that reflects the tissues or structures that limit the joint motion, whether those are physiological or pathological. So in kinesiology, Heather talked a little bit about what physiological tissues might limit joint motion. For example, in hip extension, it's generally a firm end feel. It's limited by ligaments. For knee flexion, it's often a soft end feel, and that it's usually limited by soft tissue approximation. A pathological end feel, it's limited by something that's not normal. So it's a bony block or an injury of some sort, or limited by pain. That's a pathological end feel. So you might get to a point in passive range of motion where you can't go any farther because the person objects because they're in pain. And so you don't actually get an end feel, and you document that as an empty end feel. So there are times when you don't want to perform goniometric measurements. So we talk about contraindications and precautions, and I think of contraindications as being absolute contraindications. You just do not want to do it. So the times when you don't want to do it, or motion to the segment can disrupt the healing process. So we're there to help people heal, not to make it so they can't heal. So if motion to the segment is going to disrupt the healing process, we are not going to move it. A good example of this might be someone has a proximal humeral fracture. They can't really cast that type of fracture, so they will put someone in a sling to immobilize them until the bone is healing. So we're not really going to do passive range of motion on their shoulder because that can disrupt the healing process. We can do it on joints distal to the shoulder as long as we keep that part still. So a subluxation, dislocation, or fracture, that's the example I gave in the first one, is the fracture. But if we have those other problems, we're not going to want to do passive range of motion and goniometric measurements because we don't want to disrupt that area. Another contraindication is myositis ossificans, which is calcification of the muscle. Doing passive range of motion can actually damage the muscles, so we don't want to do that either. Or if a joint is surgically fused or fixated, we're not going to perform a measurement because we're not going to change it at all. So that joint is fused or fixed, and whatever therapy we do on it isn't going to change the fact that it's fused or fixed, and so we just don't do that measurement isn't going to change, and so we're not going to bother with it. A precaution or relative contraindication. So it's something to be cautious about. You may or may not do goniometric measurements in these cases. So if someone has moderate to severe pain with a movement of that segment, and the movement might make their pain worse, again, we want to do no harm. We do not want to make people's pain worse. We want to make it better. So we're going to be really careful with that. If someone has an inflamed joint or the joint region is inflamed, that is another thing we want to be careful with. We don't want to make it worse. Osteoporosis or a recently healed fracture, in both of those cases, the bone is weak. With osteoporosis, it's a pathological process, and the bone is weakened all over. With a recently healed fracture, it just hasn't healed enough yet, and the bone is still weak, so we're not going to be cranking on it because we don't want to break their bones. If you have a hypermobile joint, you're not necessarily going to do passive range of motion and measure at their ultimate end range because we don't want to push it into more hypermobility. If someone's in the acute stage of a soft tissue injury, say they have a muscle tear or a laceration of some sort, we might not be doing it in that case because, again, we don't want to make the injury worse. But with all these precautions, we're going to be careful, but we might do it in that case. It might, depending on what the limitation is. After a prolonged immobilization of an individual part, it's going to be different. We're going to have shortened muscles, shortened connective tissues, and so we may or may not be doing goniometric measurements in that case. So those are precautions. Okay, the tool that we are going to be using for most of our goniometry is the universal goniometer. Okay, they come in different sizes and shapes. All of them have an axis, and they have two arms, one stationary, one movable. They have a plastic gauge on it that goes from 360 degrees to 180 degrees. In the photos here, the larger one with the circle in the middle, that's the 360 degree. The smaller one is the 180 degrees. Generally, you want to use the goniometer that's appropriate for the size of the joint that you're measuring. So you're going to use a smaller goniometer for hands, feet, digits, and a larger one for your larger joint movements. A lot of times we're going to use other instruments besides a goniometer, for example a tape measure, for measuring trunk motions. So with the universal goniometer, the idea is we want to be able to collect reproducible objective data to document in the patient's chart. So we're going to use that objective data the PT will determine the therapy goals. We're going to use the measurements to determine patient progress throughout rehabilitation. And we're maybe trying to decide, does this person need to keep coming to physical therapy? So it's a really simple little device, but it does take practice to accurately align it and read the correct angle in order to eliminate as much unnecessary error as possible. So that's what we're going to be doing in lab. We're going to be practicing that goniometry. And of course, the more you practice, the better you get at it. So there are some potential sources of error in measuring. One of them is you read the wrong number or the wrong side of the scale on the goniometer. So you're reading the obtuse versus the acute angle. And that one can be eliminated with practice. Sometimes if you have predetermined expectations of what the reading should be, you can sort of allow that to influence your recorded value. Like you think, oh, that's, they've got more than 90 degrees of knee flexion here. Let's just... so your expectations can affect, can be a source of error in measuring. If the patient is not motivated to perform, so read into that whatever you want to. If you have someone that for whatever reason, maybe they're afraid that if they get too good a measurement, they're going to lose their disability or something like that. There's a lot of reasons that might change a patient's motivation. Maybe they've just experienced so much pain with this injury, they don't want to go into the end range because they're afraid that it's going to be painful. So there are lots of reasons why a patient might not be motivated to get their best range of motion. So if you take range of motions at different times of the day, which obviously that can happen. When you're scheduling appointments in a PT clinic, the patient's not always going to be able to get that 10 o'clock appointment. So there can be fluctuations of swelling or joint stiffness when somebody has an injury or they're post-surgical throughout the day. And so you might have, at different times of day, you might get slightly different range of motion measurements. That doesn't, necessarily change the patient's progress, but it changes how we, the measurements that we're going to get. So if you do not align the goniometer correctly, then, or there's error in your procedure, so that's, in your alignment, that could be another source of error in measuring. So we're going to practice our proper alignment in our landmarks. So in kinesiology, we were learning to palpate all those bony landmarks. That's really important because now we're going to use those landmarks to reduce the source of error in our goniometric measurements. So we are going to talk about the procedure. We want to have a consistent procedure, and that's another way to help reduce error in measurements. So we are going to look at this. I'm going to talk a little bit about validity and reliability and define those terms. So validity, a valid measurement, means that the measurement represents the true value of the variable. In other words, it means that the goniometric value actually represents the angular relationship of the two articulating segments. So what we're measuring is what actually exists, so that it's a valid measurement in that way. Reliability means that a measurement is consistent, repeatable, and reproducible. So we want to have reliable and valid measurements. So the question comes up, how reliable is goniometry? So you can maximize goniometric reliability by standardizing the measuring device you use. In other words, use the same device every time you measure that particular measurement on a person. Standardize your positioning and landmarks. Use the same positioning and the same landmarks every time. Standardizing your procedure, which we're going to talk about in a minute, and standardizing the examiner. In other words, the same therapist measures each time. That's not always possible, and certainly as PTAs, we're not going to be the first person that measures somebody's range of motion. It's going to be the PT when they do the initial eval. But there have been a lot of studies done in intra-rater reliability, meaning the measurement I take today and the measurement I take 2 days from now, versus inter-rater reliability. So if I take a measurement today and then you take the measurement 2 days from now, the measurements with the consistent examiner, the consistent therapist, are going to be more reliable than the ones with two different therapists. So we can increase our reliability by having the same person measure every time as much as that is possible. But of course, the way things run in a regular clinic, you're not necessarily going to get the same person measuring every time. So we can increase our reliability by standardizing procedure, positioning and landmarks, and standardizing the measuring devices that we use. But there can be as much as a plus or minus 5 degree difference between different examiners, even using standardized methods. So that's just something to be aware of. It's not really anything to worry about, but just to know that you're going to get differences between people. So the purpose of measuring range of motion, joint range of motion, and we've talked about this before, of course, we measure it at the start of therapy. The PT does it when they do their initial eval to establish treatment goals. We're going to measure pre and post a treatment session to measure their progress. So we're going to say, okay, I'm going to measure this person's shoulder range of motion, then I'm going to do joint mobilizations, I'm going to do soft tissue, whatever treatments and interventions you do, I'm going to do mulligan, I'm going to have them do exercise, whatever treatments and interventions you're using. And then we measure post-treatment to see, were those treatments and interventions effective? We're also going to measure at the conclusion of therapy in order to document the patient's overall progress and their therapy outcomes. So did the person get the outcome that they wanted and that we wanted? And a lot of times with progress and outcomes, we want to link those to functional activities. So we'll say, okay, so the person's got 180 degrees of shoulder flexion, so what? What does that matter? Well, they've got 180 degrees of shoulder flexion so they can hang their coat up in their closet, or whatever they need to do functionally. So it's nice to link treatment goals and therapy outcomes to functional goals, because that's really the whole point of physical therapy. We want to help people improve their function. Okay, so we're going to talk a little bit about the documentation, how we're going to document our measurements, and there are differences in documentation, just so you know that. And then we're going to talk about the procedure that we're going to use to do it, and we will go over this in lab. So in the documentation of goniometry, the goal of the documentation, the goal of the goniometry is to provide objective data that's measurable and reproducible in the patient chart, which is the medical record. It lets us show evidence of progress or, God forbid, lack of progress. It happens, though. So you want to note the position that you measure someone in, particularly if it varies from the standard way of doing things. Most clinics or therapists have their standard way of measuring. The clinic you work in will hopefully teach you their standards. There isn't necessarily a single standard way of measuring. There are different positions you can measure people in, so you want to make sure that you stay consistent. You want to note that position you measured in the chart so you can maintain that consistency. So you are going to document a range, so you might say shoulder elevation, which could either be flexion or abduction, from 0 to 180 degrees. And just for a reference point, anatomical position is 0 degrees in every joint. Okay, so that's your reference point. So you're at your ankle, for example, in anatomical position, you're at 0 degrees of dorsiflexion, but your foot is at a 90-degree angle to your ankle, but that's 0 degrees of dorsiflexion and 0 degrees of plantar flexion. Anatomical position is our starting point and our reference point for everything. Okay, so there are different ways to document knee extension. You could say somebody is lacking a certain degree of knee extension. So you could say you're lacking 5 degrees from full extension. Full extension being anatomical position, also known as 0 degrees. You could say 0, minus 10, minus 135 degrees, meaning they're lacking 10 degrees from 0, and then they're flexing to 135 degrees. That's an unusual way to document it. I haven't seen that very much, on the West Coast anyway. You could say someone they have knee range of motion with hyperextension. You could say 5 to 0 to 135 degrees, meaning they have 5 degrees of hyperextension past 0, and they have flexion to 135 degrees. So just be clear on the way your PT or PTs document range of motion, and make sure that you're consistent with that. So there are different ways to do it, and we'll talk more about this in lab, but as long as you're consistent, that is the way to do it. Okay, so we're going to talk about the procedure for goniometry. So the measurement procedure that we're going to use consistently every time, and this is the procedure that I want you to practice. This is when we do the skills check in lab, this is the procedure that I want you to use. So the first thing you're going to do is you're going to explain the procedure to the patient. You're going to say, we're going to measure how much you can bend your knee. And you're going to demonstrate the motion of the patient. You're going to say, like this, and show them the knee bend, okay? Just make it clear so they know what you're trying to measure. The first thing you're going to do is you're going to visually assess the available active range of motion. So you're going to ask them, how much can you bend your knee? Just bend that up as much as you can. And you're just going to eyeball it, visually assess that. You are going to look at it on the uninvolved side as well as the involved side, because that's one way to tell what is the normal measurement for that patient. So we have in the textbook and in a lot of different sources, we have averages, what the average range of motion is for a certain body part like knee flexion or knee extension, for example. And I will want you to be familiar with those. However, none of us are average, are we? So some of us, our normal range of motion might not be. It might be way more than the average. It might be way less than the average. If you look in different sources, you'll see different things. So a lot of these averages are established by hundreds of thousands of measurements over lots of different people, and they end up with an average for that. It just gives you a general idea of what that joint can do. It doesn't mean that if you don't have that range of motion that you're abnormal in any way. It just means that that's the average. That's what you see. So we're just going to see what can they do on the uninvolved side, what can they do on the involved side. Then we are going to assess range of motion and end feel of the involved side. So if active range of motion is limited or painful, passive range of motion is probably going to be a little bit limited too. So we're just going to see, what does it feel like at passive range of motion? What does it feel like at end feel? So up until now, those first 4 steps, we haven't even touched the goniometer yet. We're just assessing, but we have an idea now of how much that person can bend their knee or whatever body part we're working with. So once we've done all those things, then we are going to palpate the appropriate bony landmarks. We're going to align the goniometer using those bony landmarks, and then we're going to measure the available joint range of motion. So we're going to try to be consistent with that procedure, and I'm going to go over that again just so you're familiar with it. And we'll talk a little bit about the alignment of the goniometer. So it's really important that the patient be positioned comfortably and in a well-supported way. So use whatever pillows or bolsters or whatever you need to do to support what they're doing. You want the joint in anatomical position as much as is possible. You want the proximal joint segment to be stabilized. Or you should be able to stabilize it so you can restrict any substitution of motion. One of the things that happens a lot if you're measuring someone's knee flexion, for example, and you have them seated and they're bending their knee, they get to a certain point and their knee doesn't want to bend anymore. A lot of times they'll lift their hip up, that's a substitution motion, to try to get that knee back further. Well, they're not really getting any more knee flexion. They're just lifting the hip up and they're doing that substitution motion. So we want to stabilize that hip so we can restrict that substitute motion. You want to make sure that they're positioned so the movement can occur through the full range of motion unrestricted, nothing's in the way. And you want to make sure they're positioned so the goniometer can be placed properly to measure that range of motion. So for this course, you should understand that there are different positions to measure the same joint motion, all of which can be correct. Mostly in the lab, we are only going to be practicing one motion per joint for simplicity and also to ensure enough time to cover the material. However, it's the PTA's role to think through the patient's scenario and determine the best position to test that patient in the clinical setting. If the PT has previously tested the patient's range of motion, you want to replicate the position previously used, because we're trying to have consistent, reliable, repeatable measurements. So if in this picture that shows someone measuring ankle dorsiflexion in prone with the knee bent, and so if that was the way it was measured the first time, that's the way we want to remeasure it, because it's going to change potentially change depending on the position that you put the person in. A good example of that is for ankle dorsiflexion. If you had them in long sitting, so they were sitting with their legs stretched out straight in front of them, the gastroc is now on stretch across the knee and across the ankle, and that could potentially limit ankle dorsiflexion, range of motion. So the position that you put them in, the position that the person in the photograph here has that patient in, the gastroc is on slack, and so that's not limiting any range of motion for dorsiflexion. However, if the PT first measured them in long sitting, you want to remeasure them in long sitting. You want to make sure your measurements are consistent. Okay, so just because we show one way in lab, that is not the only way to measure it, but we're kind of looking at one way just for simplicity and time. Okay, just know that there's more than one way to do it. So I'm going to go over the procedure again. You're going to explain the procedure to the patient, demonstrate and instruct the motion to the patient. You're going to assess available active range of motion on the involved and the uninvolved side. So you can do that simultaneously depending on the motion. If you have someone lying supine, you can have them bend both their knees at the same time. And you can compare the two. Then you're going to assess normal passive range of motion and the end feel of the uninvolved side. So you know what normal end feel is. Then you're going to assess passive range of motion and end feel of the involved side. So again, if depending on the position, you could do it simultaneously. Then all that before you even pick up the goniometer, then you're going to palpate those bony landmarks, you're going to properly align the goniometer, and you're going to measure the uninvolved side. You're going to measure the involved side. If it's different from the uninvolved, when you do your initial general scan, if both sides are the same, you probably don't have to measure them, because you can document that it's within normal limits for that patient. If they're different, you want to measure and you want to document the difference. Okay, so we're gonna I have some handouts with charts of the different alignments, and we're gonna go through these all in the lab. So each different joint that we're measuring. For example, we're gonna have hip flexion. On the chart, I have the joint, the motion, the average range of motion, and you know what I said earlier about the averages. Average doesn't necessarily mean normal, but that's just what it is. What the normal end feel is, the position that we're going to do in lab doesn't necessarily mean that's the only position to measure in. Where you put the stationary arm, the axis, and the distal arm of the goniometer. So I'm just going to give you an example. For hip flexion, the average range of motion is 120 degrees. The normal end feel is either soft or firm. So it's going to be firm because of muscle or ligament stretch or joint capsule, and it might be soft because of soft tissue approximation, depending on how that person's individual soft tissue is arranged. The position that we're going to practice on in the lab is supine. The axis is going to be on the greater trochanter. The stationary arm is going to be on the lateral midline of the thigh. And the distal arm is going to be pointing to the lateral epicondyle. So hip flexion, so on the chart, which you can download from the Canvas classroom, for each joint motion of all the joints we're going to do in lab, we have all those things listed. And I like my charts so much, I laminated them. So it's really nice to have that copy to refer to when you're practicing in the lab. Okay, so in the picture here, it shows the axis, the stationary arm landmark, and the moving arm landmark. So we're going to learn all those goniometric alignments. That's one of the things we're going to be working on in lab. Okay, so we talked a little bit about positioning. We want to position the limb to avoid passive insufficiency of two joint or multi-joint muscles. We want to put the patient in position that those two joint or multi-joint muscles are on slack. So, for ankle dorsiflexion, you're going to have the knee flexed, so you put the gastroc on slack. That's our example. We're going to stabilize proximal to the joint as necessary, either by the way you position the patient or by your free hand. That's one of the skills we're going to practice a lot in lab, and I would really advise you to practice a lot out of lab as well, is how many hands do you need to stabilize the joint, manage the goniometer, do passive range of motion? You need about 5, maybe 4. 3 on a good day. So you only have 2 hands, so you're going to have to learn how to do it. So you're going to align the goniometer and begin the joint motion at the 0 degree start position on the goniometer. So we're establishing our start position, and we know that's anatomical position. So we are going to then measure at the full end range, and we're going to document that measurement. Okay, so you will see different styles. Everybody has their different style. I work at a clinic where we have about 15 PTs, and everybody has their different style of measuring knee flexion, for example. We do have meetings quarterly for our joint replacement program where we talk about our differences in measurement and what ways people are finding most successful, what ways are the best ways, and we try to standardize as much as possible. So documentation styles and measurement positioning and styles, you want to adhere to the standard for the clinic or the facility where you work. That's important for consistency and repeatability. So we will do a little bit of a review in lab about assessing a joint's end feel. There is a video on Canvas that talks about soft, firm, or hard end feels. And that's kind of a nice thing to review and remember which structures determine individual end feels, and we'll practice assessing that in the lab as well. There are a lot of videos that I have posted in the Canvas classroom measuring showing goniometry measurements for a lot of different joints. You are also going to create some of those either videos or still photos for measuring an individual joint of all of these different things. Each person's going to do one separate one. But these videos are here for you just as a reference and practicing, just so you can see ways of other people doing it. In the lab, we will also do some spinal measurements with a tape measure, so you'll get the feel of doing that as well, and there's some videos for those as well. So really the main message that I want to get across to you is, in order to get better at goniometry, you have to practice. That is the best way to get better at it. So I want you to practice at home. We're going to practice a lot in the lab, and I don't expect you to be an expert by the end of this class, but I expect you to have a firm grasp on what you're supposed to be doing with goniometry.